We what? Cut.
How many are you there?
Jinko, can you say something?
Yes. I asked how many are you there?
And now we can hear you.
Now work on the video so that he's able to see how many are here.
Let's work on the video. Okay. Yeah. The camera is on.
The camera is on, but somehow.
It doesn't show like when I can see these people. Maybe because the software, the meeting, because if it was shown like it can put somewhere when you can see. Maybe he's the one who shared this.
So we are 16 in the room, Dr. Jinko.
Yes. I don't know how many are in the room. Just please let me know when I can start.
I think you can start.
I can start now.
Start because we wanted to work on the video so that you can be able to see us, but unfortunately it looks like it's taking us a bit of time to make that happen.
Okay. So I understand I have 30 minutes. So I will start. That's a good morning, everyone. But it's a really great pleasure to present to you this about this overall picture, why we need to have this capacity building for key population data. So I hope you can see the screen. As I will also record the session. I use the title Quality and Use of HIV Surveillance and Key Population Data is critical elements for sustainability. Because we're all talking about sustainability at a global stage, not only PEPFAR and UNAIDS and Global Fund, and we all talk about this. That's what are the elements that's for sustainability, including this political sustainability, political will, financial and programmatic. And the other thing that's important that we need to have system in place, including for data system for the country and for the region and for the community, that then as people can really organize themselves for different pieces of data. HIV, it's important in key populations. That's let me try to have this slide move. And so I will talk about this three aspects. One is what are the standards for HIV surveillance and KP data? That's what's the general global guidance requiring for that, and how to analyze those data, and why this regional capacity is so critical. So the surveillance, this for the KP and for HIV in general, that's I describing a few elements. The one is HIV's case surveillance, and then talk about a little about the sentinel surveillance, and then biobehavior surveillance for KP only, and the size estimation. I will not really spend time on this KP programmatic data, and because this is also a big topic. That's and we will have a lot of areas to address, but I will summarize this at the end of the presentation. These are this case surveillance. Case surveillance is basically reporting on all cases, start with diagnosis, and then follow the cases through this entire life cycle and capturing all sentinel events related to public health actions. And in WHO guidance, this case surveillance is not only the first capture upon diagnosis, also relate to this tracking of patients across this service or patient care continuum. So we have a few like sentinel events, and in out of 6, there's 3 that's critically important. There's all of them. There's so one is this upon diagnosis. This when you have this functional case surveillance, you will need to capture this the moment when this individual got diagnosed with HIV. Then there's you need to have first CD4 and to see that's where that's you have your immunity level, and then let's start with ART. Then look at this viral load test to see this where they are, because viral load is closely linked with this transmissibility and how the individual can still transmit virus to others. Then it's capture the moment of viral suppression, and then this outcome, either stay on treatment or died. So this, you can see that it's really ongoing process, and we need to have people like all the sentinel events actually captured. This very simple way of describing case surveillance. This case surveillance also need to one thing not here, that's it need to have transmission risk captured. Unfortunately, that's in Africa, there's many countries do not really have very well functioning case surveillance. Also, there's many countries start case surveillance upon this ART initiation. If this follow WHO guidance, these pieces will need to be added, especially around transmission risk. This become increasingly important when this majority of general population already know their status and they start treatment. The remaining part will be more related to key populations. The key population globally was like a starting group for the epidemic, for the pandemic, and will become the last mile of the, if we want to end AIDS. The sentinel surveillance is not like a sentinel event. It's nothing to do with that. Sentinel events is like a sentinel surveillance is like a sentinel surveillance for any other diseases. We do have sentinel surveillance for flu, influenza. We have the sentinel surveillance for STIs. We have sentinel surveillance for HIV here. So sentinel surveillance was designed at the very beginning. That's of the pandemic, that's try to understand where we are in terms of serological, basically understand the prevalence. We have sentinel groups here. There's one key populations, especially not very common in Africa, but it's very common in other parts of the world. So in Asia, in Eastern Europe and Central Asia, in Latin America, and even in Europe, we still have the sentinel surveillance among key population groups. But it's very common in Africa is sentinel surveillance among ANC attendees. And also that's in other countries, we do have sentinel groups among other groups. This locally defined key population groups. At the very beginning, that the sentinel surveillance was unlinked. That means that someone tests positive, it cannot link. You can clearly see this was error where ART was not possible. And anonymous, so one try to reduce any stigma associated with this. Purely this purpose for this is what to understand this prevalence level over time. So we have designated period of time, annually or semi-annually, usually use convenience sampling, active or passive recruitment. So active, this means that we reach out to this targeted populate the sentinel groups and to recruit the individuals. Passive, just wait for sentinel groups to come to the service sites and get blood drawn and then do that. One thing we want to, in the key population context, we want to turn this sentinel surveillance design by adding the biomarkers to and behavior, the information to this sentinel surveillance design. So other biomarkers, this except this on top of the HIV antibody, that's they can test STIs, that's to be on the sentinel surveillance sites, and also operated as the sentinel surveillance, but it's plus this very simple questionnaire to capture major behaviors and service access and use. One of the principles when we design the questionnaire is we make sure all the variables collected through the simple questionnaire are used by the program. So this is not like really a kind of research type, it's more like program oriented. So this kind of sentinel surveillance plus widely practiced in Asia and Latin America. In Latin America, there's the French, or not French, Spanish acronym called visits. In Asia, in many countries, including big countries like India, China, they're doing the Sentinel Surveillance Plus. Basically, they can have annual data over time and with consistency in the sampling and how they collect the question, their variables, and then analyze the data. So that's the Sentinel Surveillance Plus. That's the area we want to promote together with something called BBS Lite. BBS Lite will be the guidance, the called implementation tool will be published by UNS and WHO in December, basically next month of 2023. It's another version of simplified IBBS. So I will talk about IBBS later on. So if you understand the key populations, we follow WHO definition, basically only 5 groups. The female sex worker or the other sex workers, this male sex worker or transgender sex worker, basically sex workers. The second group is MSM, men who have sex with men. The third group is people who inject drugs. And increasingly, countries start to include people who use drugs as part of the group. And then transgender people. And the last group is pre-donors, those people and retained in a closed setting. So we follow exactly this 5 groups by WHO, but this locally, if we want to have some locally defined key population groups, that's it's allowable to be included in this surveillance program. You all understand the key populations are very dynamic, very mobile, very volatile. So dynamic, this means they're very active, and as a community, they play a very big role in any service delivery, designing, and also that's the surveillance. They move from place to place. It totally follow the event. That's when they have a gay community event, they can attract a lot of people for that specific weekend, for example. Also, that's sex workers follow this business where the money goes. That's so also important. That's volatile. That's the status of key population. That's so today there's some a female maybe a sex worker, but a month later that's the female find better opportunity for income, may not become a sex worker again. So this kind of volatile status makes this very difficult. And also even more difficult, there's 3 other items on the screen that's hidden. They're hard to reach, hard to access. And in many countries, certain behaviors are criminalized. There's a lot of stigma discrimination associated with their behavior or as the status of the orientation. So because of that, it's very hard to have a sampling frame for key populations. Not like we do for the general population, we can have a line listing of individuals in a specific community or in a specific area, the catchment area. The key population is not possible to have that line listing. I want to go back to first. I believe all individuals in the room that you have very good understanding about AP surveys. So we're talking about what the population we want to represent through a sample, basically a subset of this all members in that population to do that. So try to give you some kind of example here for key populations. Basically, what we want to have is targeted population. For example, I use pink to represent female sex workers, for example. Not all these female sex workers are accessible. So some sex workers you will never get a chance to access by the service or by survey teams. And then as you only can do a sample through among those accessible portion. You will never really go back to the very first step as target population. So what do we mean here? If you want to really represent the entire population, basically you want to represent the pink parts. But in reality, what you can represent is the accessible portion. So also you need to have like even accessible portion, you will need to have some kind of sampling methods in order to represent that part. So representativeness is a kind of accessibility and sampling probability. So this is this survey design part. I just give you an example. I believe you will have more lectures around this to understand the sampling process. What we want to ensure is a consistency of the results. Because of this, we do not have a sampling frame to start with all the samples. No matter what kind of method we use, either respondent-driven sampling or time location sampling. I believe people will talk about that. Respondent-driven sampling is not sampling against the population, as I said, the target population. And time location sampling, RDS respondent-driven sampling is against the network. It's not the population. I hope people will understand that. And the time location is basically on those people who come to the venues for a specific period of time. They will be able to be calculated in terms of the participation probability. So there's use something called VGT, the venue, day, time. That's a sampling frame. Even this kind of thing, there's different methods will capture different pieces. And the convenient sample really about this how convenient this sample can be recruited. And you can see there's different sampling method that will capture different pieces of the key population, target population, this entirety. So the consistency in design, in implementation and analysis, all this kind of thing become important because everyone that's all donors and also national program try to review is this the comparability data to enable trend analysis. So when we talk about this key population surveillance, you need to really be very clear about subject eligibility. For example, you include people like a sex worker that's above the 15 or about 18 years old. For female sex worker, you want to look at the people who have actually had commercial sex in past months or 3 months or past a year or past 6 months. So that need to be consistent. Also, the subject, this female sex worker, their sale sex in a specific catchment area, we should define exactly catchment area each time. You cannot have this entire Kampala city, or the other day there's only part of Kampala city. So that need to be really consistent. Sampling method I already mentioned, this need to be very clear, and also consistent. Also, the variable definition need to be very consistent. When you ask about condom use, for example, that you cannot say that this time ask about if you use condom at last client or use condom during last month. Oh, this kind of thing can be very different. You need to ask the question when we analyze if you use condom or condom usage, does need to use exactly same variable to analyze. And the second thing is one implementation. The survey site should be ideally should be the same, and the survey team, especially that's people understand the key population and also sampling part should be the same. And the laboratory results should use the exactly same method and ideally in the same lab. And the consistency in data management also important, how we deal with missing data, how we merge variables, and how we merge data from different survey sites, how we create new variables should be the same. And when this analyze data, that's what data, what software we use, how we assign weight, and inclusion or exclusion of variables also very important. So you can see that's how critical that's when we analyze from design to data analysis, how we can enable this compatibility of data. That basically is about this IBBS, that's and surveillance among key populations. I did not go detail about sampling method. I hope that will be captured. And then the next one is about size estimation. This population size estimation is still very tricky. That's in a way because nobody will be able to understand what the true size at a specific moment. And given this dynamic, mobile, and volatile the status, it's not possible to have a static the size estimation over time. People move very much, and even this month's size estimation can be very different from the next month. So, but the thing is, we still need to estimate the size because it's very important to understand the scope and nature of the key populations. Also, this is very important for advocacy, for the funding and policy change, and also for the program design and implementation, and critically important for monitoring and evaluation. Here, let's quickly summarize all these methods here. That's probably I will not go detail. If you see that none of the methods here can be served as golden standard. Each of them got the strengths and limitations, and some can predict this the direction of bias, like programmatic mapping. That's usually underestimate the size. But the other method, also the census and the elimination, usually this to underestimate the size. But the other method that is very hard to define the direction of bias can be overestimating or that's underestimating the size. So we encourage always this different methods to be used. Always important to have multiple methods to estimate the size. You need to have a kind of in consensus. Both had the site. Usually that's what we do. That's, for example, in Uganda, we have like multiple sites to estimate the size for any given key populations, and then try to generate this kind of country level and national level estimate. But this consensus should be done at both the sites where this real population size estimation exercises were done, and then when we generate the national figure. I want to point to the importance of the programmatic results. Programmatic results are critically important, and in defining point estimate. We see that in many cases, this programmatic results already higher than size estimation. That is not acceptable. So that unless you accept that you really have program data quality issue that's in the key population program, but people usually don't agree. Also, that's important. Let's say this stakeholder engagement. All the stakeholders need to be part of the consensus process. Not only those target population program people, the researchers from the university, from any academic institutions, not only for quantitative research, also for qualitative research should be part of this. Also need to get their perspectives, also get to ensure their buy-in of any number we agree to be. And the Ministry of Health need to endorse those numbers prior to any use. Ideally, we should have one number at one time for any key population groups. It cannot have, that's what we see, that people use different number of estimates for different purposes. And at a global fund, we saw that when we apply for funding, we have used a big number, and then have any excuses say that we can only work on the small number, and after we secure the funding, especially during the grant making process. And also that's what reported through UNS called Global AIDS Monitoring, called GAM. They used a number and then used another number with PEPFAR. So this kind of situation should be avoided. I move quickly. That's two last two elements. That's very quickly. That's one thing is about hypothesis-based analysis. We have been doing this analysis for a long time, but mostly descriptive. Basically look at this distribution by age, by demographic variables, and over time. That's it. We're not testing this any hypothesis. I hope that all the analysis, all these people here that receiving this training, that need to come with ideas. What is the hypothesis analysis? How important at that? Because at the end of the day, all the analysis need to answer the question that if our program is working or not working, which part is working, which part is not working, and what kind of changes we need to make in order to make it working. So data collection and analysis is kind of continuing. That's what we want to improve the program. So data for analysis here is we have both quantitative and qualitative data. And they are equally important. And especially during this interpretation of any quantitative results, qualitative data is important. So we need to map all the data. That's I suggested this during earlier design phase. We need to create data repository. That's we do have some kind of issues, and especially when we hire external consultants to do the analysis, and then they compile all the data and finish this report, and then all the data are gone. So nobody is taking care of the data repository. Data repository that may not be like really every very idea, but the thing that we should continue improve the data repository and find a central place in each of the countries to situate and someone responsible. I can ensure you that's because I have been supervising different students. When you have such data repository, you will be able much easier to have your students, master or PhD students, to do the analysis. And to align people to share the data, and then if you create a database, it can be shareable among all the people who are interested in data analysis. When we try to interpret the findings of the analysis, what we try to do a lot of things that we cannot really have a causal relationship established. What the hypothesis always try to address is to understand what worked, what did not work. Basically, it's about this causality. That's if this actually contributes or even attribute to something that we observe on the other side of the extreme continuum from input to impact. So what do we suggest here? Because we are dealing with real world analysis and data, we call something called a plausibility argument. And need to assess this what program actually factors and actually contribute to something we observe on outcome and impact part. What are the other non-programmatic factors may contribute also. So that saying that we need to have that kind of label. People are talking about climate change. Probably that's in the case of malaria, or and during COVID, these other factors actually contribute to the access of services because of lockdown and other things. That's people may not have access. This is purely non-programmatic factors. People will not be able to sell sex, or among MSM, they will not be able to meet. So that's may have caused this reduction in HIV new infections, but that is not a programmatic factor. So just to give you an example, that's I will not go detail about this, but the critically important is hypothesis and following this plausibility argument. The last piece, that's we try to have something from the region for the region style. That's we find that you fly in this experts to global experts from Europe and the United States may be helpful in the short term, but it's definitely not helpful in the long run. That's so I mentioned about this sustainability at the very beginning. If we want to make things sustainable, that's you need to have a locally built capacity in the country and or in the region. That's the major reason we are working with Makerere University School of Public Health here, really to build this capacity in Eastern and Southern African region as a to have the capacity readily available for deployment, and also that's ideally being part of the program. If you can understand this, the IBBS, for example, the size estimation, they're being done as every 2-3 years, or even in some countries every 3 to 5 years. That kind of demand will not be able to sustain a team and in any institutions or in any program just for that piece of work. So need to be institutionalized in kind of this academic institution like a university or in the community to they can do routinely the program, but periodically they can run the survey like the IBBS. So they have a few areas to build this capacity. That's I will not repeat what I said about surveillance and also the patient tracking or analysis and use. I spend like 1 minute about mentoring. So we want to create this kind of program, big ongoing. So you will have a mentor from the university and or some partner network university. You can serve as mentor for the program people, and they're working in the community. They can provide ongoing support, keep motivating people to do this data collection and quality and analysis to serve the purpose for the use. Need to help the mentees to resolve their own practical issues. It's not like only something that's to classroom, and then when they go back, they will need to have real assignment, and then can have the opportunity to answer some of the questions they encountered during the program, and any this either program data or the survey data or whatever. So that's that kind of real issues can be addressed. So that we call this mentoring. And by this kind of program, we aim for this kind of first. You guys are the first cohort of casuals. Then it can be some of you that may have opportunity to do consultancy in to support the countries, and that we already see that's in other regions. So the well-trained, the first cohort of technical staff that can be deployed to other countries. And through this kind of example and practices, you can further increase your capacity to do this. In summary, that's what you have here. This is a wide range of different things. It's a lot of things to learn. I don't think anyone can be real expert for everything. That's including myself. We cannot be expert for everything. But we can see that's how we can work together as a kind of a team, and also that's have the cross learning among ourselves to elevate the level together. Thank you very much. Let's see if you have any questions.
Thank you, Dr. Jinku. I think at this point, let's have some questions.
Just wanted to know, apart from the slides, are there any related material that maybe can support the understanding of the issues in the slides?
So, Jinku, did you hear that?
I'm sorry, that's the volume is too low or distant. I cannot hear.
Are there any materials that you may have that support the slides that participants could benefit from? That's the question.
Okay, so I can share with George the slides and some materials, some reading materials.
Thank you.
Yeah.
Yes.
I would like to ask you about the role and the place of modeling in terms of responses, programmatic responses for HIV, where you model to identify the main issues that will be driving the epidemic. Yes, within the need. And especially now we are talking about the epidemiological and clinics-based modeling with the climate aspect and all that, and how that is being taken up in other countries, where is something we can.
So the question here, colleague,
Yes.
from a colleague in Kenya, what's the place of modeling in order to understand the key drivers of HIV amongst these populations? And what's your experience on how that is working in other countries, how modeling is being used?
The modeling is part of this entire strategic information is critically important, because some of this data that's not available in many countries, that's through data collection, also or not in time. Some of this surveys or this kind of exercise can be done only every few years, and modeling is done every year. Let me put this modeling in two pieces. One is this, the spectrum. Some of you may have been part of that. It's annually done. That's led by UNAIDS, and it can generate the key output, like people living with HIV new infections, and by some subgroups, by age or the geographic areas. So that is important for the planning and for also qualification of commodities, and even for the budgeting purpose. The other thing, this other part of this, really understand this dynamic of the epidemic. So that is the requirement for this models itself is very high. So we do not have this very good model yet. I must say this, in the modeling world, we have a saying says all models are wrong, some are useful. So probably you have heard this saying about this. All models are wrong because this models always come with assumptions. When you do not have data, you borrow data from others, and what such borrowing that may not be good, and you adjust that borrowing and then something that you can put in the model. That kind of something called dynamic model. Dynamic model, that's basically you need to look at people's behavior. For example, in the sex worker, there's how many clients you had in last month. Are there any dynamic? Do you know there's other clients' HIV status? Do you know if the client got STI? And if we know this client got other sex workers and a whole dynamic, that kind of thing. So if you understand that kind of level of requirement for the variables as input to the model, it's almost impossible. And one of the model called S epidemic model is applied in many concentrated epidemic countries, try to understand about key population dynamic. That is more dynamic. That's only applicable in a few countries. Unfortunately, that's in Asia, because the requirement as input to the model is too high. And the other model that's called GORS, probably that's with John Stover. Some of you have been working with him. Also, that's try to understand not only that's with the behavior, and also with this costing data, try to understand this how investing in certain piece of the program can have an impact on the new infections. So that is also useful in understanding the dynamic of epidemic itself. I don't know if I answer your question, but the same as modeling is a critical piece of the strategy information for in HIV response. But this data requirement for the input for this very dynamic model is still limited.
Thank you. Other questions? Dr. Jinku, it looks
Okay.
don't have additional questions. We want to appreciate your time very early morning. And thanks very much. We hope you can share those slides and the materials that you have promised so that we pass them on to our colleagues participating in this training.
Thank you. That's on behalf of Global Fund. I really appreciate this SPH, and also there's all the participation from you. That's I wish you a successful week and also successful program.
Thanks very much. Bye-bye. I think it's gone. Okay. We proceed with our